Thank you very much, Cornelia. Thank you very much, Rocco. Thank you for inviting us to this group. I am very much looking forward to it and try to share my screen. Is this working? Can you see the slides now? Okay, so I'm starting the presentation. Okay. Yeah, coping with Corona, the role of hospital care structures and capacity expansion in 5 countries is the title of our work. I will give a short introduction. I will come to the pre-pandemic situation and then to the responses to the pandemic in the 5 countries we selected and present a summary of findings. And Cornelia already was so kind to introduce the co-authors, all my co-authors. As you see, country experts from a bunch of countries, from 5 countries. We have produced this report for the Bertelsmann Foundation, which is available, unfortunately, in German language only, but it is free for download for those of you interested in this information. This report is it is a collection of data, a wealthy collection of data from these 5 countries and the reaction to the corona pandemic from the perspective of the hospital structures. And yeah, I'm really glad that to be here now, because the intention is to produce from this data collection a scientific paper. And as I understood, still the Euro Health Policy Group is a place where work in progress can be discussed. And so for you to know, the intention is to give some analytic perspectives on this rich data collection. And that is why I'm so glad to be here in this round today. What is the work about? It is about the first wave of the COVID-19 pandemic, which is more or less about the same time span in the 5 countries, ranging from January, February 2020 to June, July 2020. And the main focus is the management of hospital capacities as a major challenge, as Cornelia already said, which affects the healthcare systems all over the world, and in particular, the capacities in intensive care. The countries we look at are Denmark, Germany, Israel, Spain, and Sweden. I'm aware that some of my co-authors are have joined us also today, and hopefully they are able to provide insights from their perspective, from their countries as well, in the discussion that follows. That would be, I think, very helpful. Here, a short overview on the countries we selected. We look at Germany as a social health insurance system where regulation is a mix of self-regulation by corporate actors, state regulation, and competition. And also the hospitals show a broad ownership mix of public and private hospitals, non-profit and for-profit. Israel is a social health insurance country as well, with 4 sickness funds, so-called health plans, which are responsible in this country for the provision also and for the payment of services. About 50% of hospitals beds are state-owned in Israel. About another 30% are owned by the largest health plan. Sweden is a state-led healthcare system where the majority of resources is publicly owned. Hospitals by the provincial parliaments or regions. Similarly, in Denmark, we have also a state-led healthcare system. Here, there is a particular integrated system of hospitals spanning also outpatient care. And this healthcare system has experienced a large movement of centralization and concentration over the past decades. Spain, also state-led, but by contrast, is strongly decentralized. And what is worth mentioning also in the Spanish case is that about 40% of all hospitals here are private, which equals about 20% of all hospital beds. The key characteristics of resilient healthcare systems we take as a measure for the quality of the response to the pandemic, we derive from the OECD. These are flexibility and adaptability in the use of the existing resources, as well as planning for the response to surge in demand. Second, the ability to create surge capacity in 3 fronts, which are staff, supplies, and space. And what is also most important, the ability to avoid excess idle capacity. Coming to the pre-pandemic situation, we start by having a look at the availability of hospital acute care beds per 1,000 population in these countries. And here you see that, of course, Germany is the availability of hospital beds is much higher compared to the other countries in our samples and also compared to the OECD average. But a first point I want to make is that it is not the available capacity is the relevant factor, but it is rather the share of non-occupied beds. And you see this gray bar in Germany is only slightly above the OECD average. So this situation for the German case indicates already a situation where available hospital beds are also filled with patients. So we have to take into account a situation also of overtreatment, perhaps, as in particular knee surgeries and hip surgeries, for example, in Germany, are much more prevalent than in other countries. And what is important to note, this situation of overtreatment also refers to intensive care. It is known that for the German case, the number of intensive care bed, as we will see later, is also high, but occupancy rate is also high. Another country I want to mention in particular, another situation in the country I want to mention in particular is Sweden. Here we have the lowest share of hospital beds per thousands of population in our sample. And we know from national statistic that these beds have been occupied already to 100%, so to speak, or even more, before the pandemic, indicating already access problems that existed before the pandemic, at least in some regions, in some Swedish regions. The fact that Germany has a high number of hospital beds leads to a figure when considering the nurse to bed ratio, which is particularly poor in Germany. If you compare the countries, the best nurse, or the highest nurse to bed ratio we observe in Denmark, and the worst, so to speak, nurse to bed ratio in Germany. In all countries we surveyed, it was reported that there is a lack of health personnel, although in particular it was mentioned by the Israeli and Swedish case study, though this is most probably a problem applying to all countries under consideration here, and all or most Western countries affected by the pandemic. We also considered the degree of specialization and concentration of the hospital landscape for our study. And here the assumption is that hospital structures where we have highly specialized and complex care geographically concentrated are better able to providing adequate care to COVID-19 patients. However, the lack of comparative data here, and above all of comparative concepts for describing and measuring specialization and concentration, put a severe limit on our research. So we have only tentative results for the countries in the study. In Denmark and Sweden, we have the most centralized and specialized hospital systems. Hospital systems in this sense are integrated systems, not the monolithic units of a hospitals. They are integrated, also covering outpatient services. In Israel, the situation is that lung wards or wards for pulmonary diseases are not broadly available. They are concentrated in the city of Jerusalem, and there are underserved areas which are located in particular in the north and in the south of the country. Germany, we have a situation that we have many small hospitals which are quite dispersed, and only few hospitals are specialized on pulmonary diseases. In Spain too, most hospitals are small, and here, interestingly, specialist care is widely distributed among these countries, and rather among the hospitals, and rather evenly distributed. Looking at the situation in intensive care, we see here the figure for the beds numbers per 100,000 populations. Again, Germany is a country with the highest availability of intensive care units, but it is also worth mentioning that also Israel has a very high level of intensive care units. Here it is worth noting that in particular the reserves are very high, so we have a high number of ventilators on top, which are on stock in this country. That is due to the permanent crisis situation, also from the military or political side, prepared to set up a large amount of ventilators and intensive care beds. It is important to note that for only in Sweden, before the pandemic, up-to-date numbers on intensive care capacities were available at the time of the outbreak of the pandemic. Sweden has a register since 2001, which was updated daily after the outbreak of COVID-19. In all other countries, the data on intensive care beds were outdated. And on top, even after the outbreak, data reporting proceeded at very different pace. You see here the dates until when the updates were completed. In Denmark, it took until March, and Spain end of March. Germany was ready with the data around mid-April. And still the data needed correction, which have been done in autumn 2020 and led to some irritation by scientists and by practitioners. Israel was the country that completed the data update by July 2020. And what is very important to note is that the data on trained nursing staff in intensive care is not available in any of the countries until today. So coming to the responses to the pandemic, we first looked at how the governance or the existence of a central planning during the pandemic was done by the countries. We see that that the central plans were quickly developed in Israel, Denmark, and Sweden, but not in Germany and Spain. In Israel, there was a direct line of communication between the Ministry of Health and hospitals. In Spain, by contrast, we had a complete lack of central planning, and we had also a lack of coordination among the regions and between the region and national government. Therefore, procurement in general was poorly coordinated, and initiatives by the central government came late and not coordinated with the autonomous communities. In all countries, with a notable exception of Spain, hospitals received the central guidance to postpone non-elective surgeries. In Germany, all hospitals, even small clinics, were compensated with a lump sum for each unoccupied bed in the first wave. Thereby, in particular, small and medium-sized hospitals were favored and large were advantaged. This was corrected later on. I'm going a little bit quicker through the slides. My time is already over, as I see, more or less. In Spain, field hospitals were constructed and they were extensively used also, while in Germany there was a hospital was built but was not used later on. The capacity expansion was particularly rapid in Sweden, Denmark, and Israel through this direct line of governance. Yeah, this is important. Here we see an example for the increase of capacities of ICU beds. Here you see the Swedish example, and what is evident from this graph is that the capacities of ICUs were very quickly set up, and also, that is the important bit, closed down as soon as they were not needed anymore, really avoiding idle capacities of ICUs. Spain, we have seen that Spain had immense problems, but what I want to mention here in particular, that in Spain it was possible to increase the beds at those points where they were most urgently needed. This is a special pattern we observe only in Spain, and is worth mentioning. In addition to the capacities of hospitals and their expansion, it is also important when looking at success or failure to coping with Corona, at how the cases, the mild cases are shifted to the ambulatory care sector and how physician-patient contacts were reduced. And here we see Sweden and Denmark with an extremely rapid navigation of COVID-19 cases through the healthcare system right from the outset, right from the beginning of the pandemic. In Denmark, for example, patients experiencing symptoms were not allowed to visit the primary care providers or hospitals directly, but use digital solutions to get in contact. Germany is a digital laggard, and here the digital solutions also increased, but it required, for example, a modification of the benefit basket to include teleconsultations in order to reimburse this for the providers. What is also interesting is that Sweden offered a self-test for the population already in May 2020, something that happened in Germany 1 year later. And in Sweden, the test material could be ordered via the internet or by telephone to the patient's home already in 2020. So quickly, to sum up, we find a high level of acute care beds in Germany that provides a buffer, but is no guarantee for adequate crisis response. The occupancy rate of the bed is decisive and puts the limit. The staffing is a crucial bottleneck in all countries, in particular with the availability of highly qualified nurses. A main deficiency against this background in all countries is that the data on nursing staff are not available until today. Sweden and Denmark had particular structural advantages due to a concept of specialization and centralization and the integration of hospital systems, so they were able to rapidly navigate the cases through the healthcare system from the very beginning. We further see that maintaining intensive care capacity is costly. A functional equivalent is the rapid adjustment, just as observed in Sweden, Denmark, and Israel. Indispensable to this flexibility is the availability, again, of data. Here, the centralized decision led to a quick, better performance in terms of speed. In Spain, by contrast, the autonomy of regional and even local governments led to a very even regional distribution. So we see a tension here between speed and participation and regional distribution. The potential to shifting light cases to their outpatient systems and keeping physician-patient contacts low is a crucial success factor for these countries. So the degree of digitalization of the healthcare system is also crucial to strengthening the resilience of healthcare systems in this crisis situation. Thank you very much.
Thank you, Mariella. Thank you for your presentation and the detailed insights. And Laia, I turn over to you as quickly as possible.
Yes.
Thank you.
Mirella, can you stop sharing, please?
I try.
On the top, I think you'll see stop. Now, yeah.
Great, okay,
yeah.
Thank you.
No worries. Okay. Can you see the slides?
Yes,
okay.
Thank you.
So thank you very much for inviting me to discuss this paper, and thanks the authors for putting that together. It's very interesting and I enjoyed reading it. So let me just jump into my discussion. I'll follow the outline of the paper. So first an introduction, and I'll try to make like it a wider perspective of the topic. Then I'll give comments on the two main sections on pre-pandemic and response to pandemic. And I'll ask some questions in the discussion that I guess they can follow afterwards with the audience. So to start with, this is a very interesting paper that really touches on a relevant topic on hospital care structures and capacity expansion. It's looked at from the COVID-19 perspective, looking at pre-pandemic and response to pandemic, using several indicators in both groups. It's a comparative analysis across countries, and that's one of the strengths of the paper, that there haven't been many yet. I found one which is more global, but in that detail and looking at several indicators, there are many things yet. So it's important, and I think it comes to the point where we know that comparative analyses are not easy to do because the data sometimes is not comparable. But I still think that it's needed. So it's good that we do that. It contributes to the literature in several aspects, I would say, on the hospital part, so in the structure, efficiency, resilience, and capacity of expansion, but also on the health system responsiveness in a pandemic. So how did we manage it, and how can we be prepared for a future one? Hopefully not, but we always need to be ready for that. And also in the literature of international comparisons. So, which can be, I think in the paper, when you present that, you could also say that it builds within this international comparisons literature. And if you look at some papers looking at that, maybe the structure that they work with the comparison can help you also building the paper. Let me just go a bit wider first, why this topic is relevant. So why hospital efficiency, performance, and structure is relevant. It has been there before COVID. So there are several papers looking at that. And let me just jump just a second to the UK, that during the last 20 years, the NHS has been trying to improve hospital care and efficiency at the hospital level. So there have been several policies trying to improve that and improve performance. For example, the DRGA system, competition, so the patient choice in 2006, several pay-for-performance approaches, like they trying to incentivize date case or the reduction of readmissions, or publishing hospital indicators to be transparent across the system, and also involving the private sector. But there have been several measures in order to improve hospital care and efficiency. So this been there for a bit already. In terms of hospital capacity, before COVID, there was something that was there also. So there are reports from WHO looking at number of beds, which is kind of the measure that it's been used the most in terms of hospital capacity, but also workforce ratios. With COVID, this has been even more important, and the papers that looked at hospital capacity, now they are also introducing the ICU beds, and also keeping with all number of beds and staff ratios, and also including ventilators as an extra measure of hospital capacity. In terms of COVID, apart from looking at the hospital capacity, there's been the relationship between capacity constraints and health outcomes. Do we see a relationship across them? And there's a paper, a report from the Health Foundation looking at that. So is that capacity constraint having an effect on mortality? And I just wanted to say that because even if it's a bit out of the paper, they see that even if capacity is important, it very much goes together with lockdown measures. So they saw that countries that had higher capacity had lower deaths, but they couldn't really link that relationship straightforward, because these countries that had higher capacity, at the same time, they implemented lockdown measures before than the other ones. So I wanted to say that because capacity is very important, but it's very much interlinked with other indicators in a pandemic like we are facing. So now let me go to the paper in detail. Basically, this paper looks at pre and response to pandemic, not post yet, response with several indicators. You are aware in the paper, you say that you are not capturing everything. I know it's difficult, but I think there are a couple of things that could really help pushing the paper, and I'll go in detail later. And the objective, it's set at the beginning, and it's important, is basically to understand the crisis reaction of 5 different healthcare systems during the first wave. So we are only looking at the first part of the pandemic. You are looking at 5 countries: Germany, Israel, Spain, Sweden, and Denmark. They are all very interesting, and they face the pandemic in different ways because they are different systems. But I think I missed why are you choosing that ones. I know that they cover several aspects, so tax-based, they cover social health insurance, even a bit on private in Spain. But I think more emphasis is needed, because what we've seen in other research is that sometimes this type of system matters to explain how the system works. And for example, in innovation, what we see is that it depends on the type of system. Some countries might be more prone to innovation than others, and this can be very much related to the type of system, the healthcare system that we are facing. So it might be relevant to explain a bit more on that side. For the pre-pandemic part, so you are looking at these main indicators, which I think they are well identified, because it's what I found in other papers looking at hospital capacity and structure. So basically you look at bed availability and occupied beds, and workforce in nurse to bed ratios, specialization and concentration, ICUs, and data availability at the intensive care level. The only thing that I missed in that part is a bit of context, because you dive straight into these main indicators, but the situation pre-pandemic, can come by different reasoning. So I just want to bring Spain here because it's the one I maybe know the most. So I wanted to say that in Spain, due to the financial crisis, there were some measures in place, some austerity measures that came during 2010 and 12. That this was a reduction in public health expenditure. They closed wards in hospitals, so they reduced the number of beds. There was a reduction in investment, in equipment, reduction of wages, and no replacement of doctors. There were some non-residents were denied access to healthcare. There was co-payment and privatization introduced. So I want to say that because this context can explain how ready was Spain before the pandemic, and this might have an effect on the quality of the service and the access to it, and to a later extent some health outcomes. And I found this paper from Borra et al. Looking at particular this crisis, these austerity measures on health outcomes. But maybe I know that you cannot explain everything in each country, but maybe a sense of why some indicators are the way they are pre-pandemic might be relevant. For this part on the pre-pandemic, these are on the way you present that it's in several graphs, and then you explain it in several paragraphs. But usually when we look at comparisons, and what I was aiming to find is a table summarizing it, because it helps comparing the indicators and across countries. Maybe I missed one number or something, but and it's a very simple table. I know it can be edited much nicer, but I think that it could help you in terms of presenting that part, even as a wrap up of the section, because you can see you can spot the differences across the countries and per indicator. And I just highlighted in yellow the ones that are more extreme in each of the indicators. So this can give you an idea of how to explain also the results. So I think a table like that can really help pushing that section. For the response to the pandemic, the indicators that you talk about are in line with other reports that I found, and that are really the ones that you need to look at when you do a comparison like this. So governance, patient pathways, hospital capacity, increasing intensive care units, staff, and alternative methods. And here I think that you are presenting that well, but maybe a table like the one I showed before could also be helpful to wrap up. But here what I think it's missing is a bit more on COVID-19, because even if you say that you cannot provide all the information and it's quite difficult to show everything. In this case, I would show a couple of graphs, like for example, for these ones, showing the number of cases per country and the number of deaths per country in the period of the analysis, which is the first wave. And this is quite easy to get from the Johns Hopkins University. And you can do it by country. So this, I want to say that because the response to the pandemic will be very much linked to the number of cases and deaths and hospitalizations that these countries are facing. And you can see that Spain has been hit badly compared to the other countries. So the response might be different also due to the impact of the pandemic. So in that section, I would start with explaining a bit on COVID and then move to the indicators. But in terms of the indicators to the response to the pandemic, they are very interesting. And I think you get a lot of information there, showing that governance and politics is super important as an initial response, and centralization matters in this case. I just want to say that elective surgeries in Spain, maybe they weren't stopped coming from the government, the central one, but they were stopped regionally. Maybe not all the regions, but for sure I know that in Valencia they stopped. So this happened too, because basically they had, it was massive the way, how the pandemic hit Spain. I also find very interesting when you talk about the private sector, how this was used, but at some extent, it was maybe not used as much as the government would have liked. So there were some constraints to use the private sector at some points, and also the field hospitals. So, and you said that in the presentation, there were many hospitals built to help the system, but sometimes they weren't really used properly because there was shortage of workforce and resources in that hospital. So it was not, they were not fully ready. So sometimes they weren't used, or sometimes they weren't needed at the end. And another point that I would like to raise in that section that maybe could be interesting to look at is care homes. So the management of the care homes was also important. And I'm going back to Spain because they were badly hit in that case. And the management in some cases and at the beginning is that the patients were treated at the care home. So this reduced the amount of patients going to hospitals. So maybe it would be interesting to look at this perspective too. And just in terms of discussion, so I guess the way you put together all the information from pre-pandemic and response, and then the discussion is very interesting. I just maybe I would add a couple of more things in terms of like maybe looking forward, like the learning curve. So basically the COVID came, hospitals weren't prepared, doctors didn't know how to treat it, but now it would be interesting to see this response in the second and third wave, because now we know about the disease, we have some effective drugs. So we saw that since dexamethasone was introduced in the hospitals, there was a change in the perspective of the treatment. So the health professionals now are more engaged and they know more how to treat the disease. So this has an advantage. Another thing that it will be very interesting to look at, and in the future, and even maybe in the discussion to name it, it's the waiting list due to elective surgery. So the backlog that we are facing, and recently it was announced at the NHS that we might need 3 to 5 years to catch up. And this is tricky, and at the same time it's not easy, because there is a new report from the Imperial College looking at this in the perspective of how are we planning the future now. We'll need to include all these elective surgeries, so we'll need to go into the routine care, but at the same time, we'll need to leave some space for COVID-19 response. So this might be interesting to look at also in the future, but all elective plus COVID at the same time. Also, the non-diagnosed disease during this period, consequences of that. And it was very interesting when you talk about digital health, telecare, online appointments, that some countries, and Germany, for example, you said, that really picked up on this. And the question is it here to stay? Do you think that when I will want to go to the GP, we'll be doing online appointments? So is it something that will stay due to the response to the pandemic? So that's something interesting to talk about too. So that's my discussion on the paper. Happy to answer questions. If you want the slides, I'm happy to send it, and happy to have a chat also with the authors. Thank you.
Thank you so much, Laia, for your really comprehensive assessment of the paper. I really think that Mirella and colleagues, they find it helpful and will address lots of comments from you. And in the interest of time, I would say that we immediately go to the discussion now. So we have some questions in the chat, and I would like to go to Zainab and
hi, Tori.
a question.
I'm all right. How are you?
Okay.
I think you need to mute the microphone. Okay, that's
fine.
Okay, thank you very much for the interesting paper and lots of information, and I really appreciate the comparative analysis. We need so much this type of comparison to go forward. My question, what questioned me, and in general in the crisis time, including in France, the issue about the capacity of ICU beds. Initial reaction in all of the countries was, oh, we didn't have enough beds, as if a question of ICU capacity. That was the key element to better deal with the pandemic. Many countries looked at Germany as like the high standard because they had so many beds, without looking into the number of nurses going with the beds or other issues. So it's actually very interesting to see. I was quite interested in the differences across countries, but also the Spanish data is very interesting because you show the ICU capacity by region and the increase in the ICU capacity. And it's interesting to see that it doesn't matter, differences are threefold or fourfold in some areas. It doesn't matter how many beds they had, they proportionally increased. You know, wherever they started, it was never enough that you had that many beds compared to another region. So it really asked me the question, because we actually had to do several restrictive measures in France, justified by the fact that ICU units were underwater and they couldn't take it anymore, patients. So without really asking the question about what are the alternatives, if it is possible to use these beds differently, or it's all about like patient management and treatment option, isn't it? We know that there are variations in medical practice, and this is very little talked about. I think we will have some lights from other papers as well today, what is going on in terms of treatments. But what is your take on it? You didn't really mention that in the paper. Do you think this could be linked to this capacity issue, actually could be linked to differences in medical practice, and what you have in hand also determines your reaction to pandemic too? If you have a lot of beds, you tend to use these beds. If you have less beds, probably you actually innovate and find some different way of dealing with the same patient.
Thank you so much, both, Laia, for your extensive reply reaction to the paper, and very interesting new food of thought for me. Thank you, Zainab. How shall I proceed? Shall I start with Laia? Cornelia, what would you suggest?
So may you first start with the question of Zainab, and then
Okay.
we will come back to Laya.
Okay.
Okay.
Fine. Okay. So Zainab, I agree. I fully agree, and I want to emphasize that it was not only of the situation in France that the directive was to increase ICU capacities. Even in Germany, where we had this huge amount of ICU beds compared to the other countries, the directive was clear: increase capacities. But it is not so much the point I want, or I think we wanted to make, is that increasing capacity is wrong. But there are two points that are important to know on top. The first is evidently there seems to be a way not only to increase capacities quickly, but also to reduce the capacities as soon as waves flatten. This is the first important bit, that for future situations, similar situations, and this also touches upon the learnings that Laia mentioned or required from our insight. For future waves, it would be important upfront to know not only how to increase capacities, but also how to reduce it. The building up of capacities in ICUs is extremely costly. In Germany, 50,000 euros per bed were given to the hospitals to increase, to add another hospital bed, ICU bed. And therefore it is very important to look at countries like Sweden, Israel, and Denmark, who found also ways to reduce the number and to avoid idle capacities. And the second point we wanted to make is, again, the number of nurses is decisive. It is not useful to have intensive care beds without staffing them, without being able to staffing it with trained nurses. And here, I find particularly important that concepts are required also to retrain staff. In Germany, it was on the broad idea, the general idea was to retrain staff from non-intensive care to intensive care. And unfortunately, this was done without any concept or guidance. So in the end, the nurses that have worked for 10 hours or more in intensive care had to retrain their colleagues that were not trained to work in intensive care. So for future preparedness, it is important to have a concept to provide crash courses for example, it's just an idea, for the training of intensive care staff. Okay. I could perhaps this fits. This perhaps fits to Laya's question relating to the work of the colleagues from the Imperial College, how to reduce a backlog once the acute situation is over and the surgeries that have been postponed have to be performed. I really wonder how this will be done in the future. My idea is that that there has been a huge change of treatment patterns, not only because of the emergence of COVID-19 patients in hospitals, but also because patients stop seeking care. in Germany at least, patients avoided surgeries and to visit the hospital. So I think we witness now a complete change in care patterns, and we do not already know what this how this develops. And we also do not have yet the data on how this pattern changed. So it is one thing to trying to reduce the backlog. The other is the patients that are not coming to the hospitals anymore. Situation in care homes, in particular from the Spanish point of view, extremely important point, as the situation was very, very tense, very dire situation. With we see that in Spain, indeed, that a high amount of patients were dying in care homes or were coming from care homes, and this has been a blind spot also in Germany and in most of the other countries. The only country, and I think Ruth, she was here now. Ruth Weitzberg would know more on this. The big advantage that Israel had is that the institutional divide between hospitals and the long-term care institutions is not as sharp as in the other countries we looked at. So we really saw that that Israel was doing far better in avoiding deaths in nursing homes or in long-term care institutions. That is not identical with our idea of care homes, because these are more like hospitals, long-term care hospitals. Yeah.
Mirella, can I shortly step in, please?
Yes, sure.
Because we have some other questions, and Laia, she was so friendly and give you the opportunity to contact her again. So I would love to use the opportunity to have some other questions too, if this is fine for you. Yeah. So then I would like to go to Iris Wallenburg. She raised her hand, and then after that we go to Ricarda Mielstein.
Okay, yeah, well, thank you. Thank you so much for this very interesting paper and both presentations, actually, from you and also from Laila, and the discussion we have right now. And I think there are so many details to go into. And I have two comments, one to pick up on what Zeynep said and say a bit about the Netherlands, and one suggestion, because you asked for that for the paper as well. Maybe to pick up what Zeynep said about how many ICU beds do you have and how are patients being treated, and maybe the differences between those medical practices. What I learned from the Netherlands, that we are in the Netherlands quite hesitant already by bringing very vulnerable elderly to the ICU department, because they have only a small risk of making it through it, and they will suffer from very heavy treatment already. But during the crisis, this was even more the case, in the sense that, well, during the first wave, like, everybody who needed this was actually brought to the ICU department instead when they were very vulnerable. And I think it was in the second and the third wave that ICU doctors already went to the nursing department when someone was admitted to the hospital. They decide, will we take this person to the ICU department if they deteriorate, or won't we? And then they will die, of course, at the nursing department, and they will have medication to give it at least a soft death. So and many of those medical practices have been invented. I think we know it from the Netherlands, but I guess it's also in other countries. And that's one of the interesting details maybe to look into. But for this paper, I thought, because I read it and it was very nice, but also very descriptive still. And that's also what I think what you said when you introduced the paper. I think it would be very nice to go more into the different policy strategies that have been developed in those countries. So what did they want to achieve, and how did they try to do that? And how can you explain whether they succeeded or not, looking into their institutional contexts? So what you presented in the slides about private beds and public beds and all these kind of institutionalized characteristics, do they help to explain the strategies that have been developed and whether they succeeded in those strategies or not. So I think that would be a way of or a line of argumentation to bring those findings more together and also to give it more of an in-depth analysis. And there are many more other things to pick up on, but I think I will leave it also to others.
Thank you very much for these suggestions. You're absolutely right. This is what the paper needs, to go more into the policy details, to the institutional context. Again, referring to what Laia said, she's absolutely right. The context, it's very difficult to separate the context from relevant factors to non-relevant factors, or in principle, we have to admit that so many other factors like age structure, and the speed of the special pattern, how the pandemic spread amongst the countries, for example, are important. It is really the challenge to separate these from the institutional context that is relevant for our paper. This is the big challenge, I think, here. And yeah, and again, Iris, thanks also for your information on the Netherlands. Interestingly, we find also there's a paper by Kanagadides from the German Intensive Care Association, DIVI. And they found out that in Germany, compared to other European countries, there have been more elderly persons have been hospitalized in ICUs. So this again is a difference in practice pattern that in my, or according to my insights, clearly results from the fact that we have so many ICU beds, and again indicate overtreatment. Because for many of these very elderly persons, it was not beneficial to treat them in ICUs. It was the consequences after treatment were particularly hard for these patients.
Thank you, Mirella. One last question from Ricarda, please.
Yeah, thanks a lot from my side as well. I always love comparative papers, so it's a treat here. Also, thanks a lot for your insights, Iris, on the Dutch situation. And I think in comparison, Germany's response was very much focused on the hospital sector, and only later dawned upon us that was actually the outpatient sector saving us, and it was not that much due to brilliant policy responses, but rather the system design as such. I do have a couple of questions on the nurse to beds ratio, though. I was wondering whether you've considered moving towards a nurse to patient ratio, which would be even more uncomfortable for Germany, because given that Germany has very long waiting times and a very long length of stay and a high caseload, this puts even more pressure on nurses. There is one aspect, though, I think it looks a bit different for ICUs and for ICU nurses, because on average our ratio of nurse to patients is at 1 to 2.2, following roughly the recommendations of the DV. So I think that the situation in ICUs is not as bleak as in other parts of hospital, as in other hospital departments. And I would also like to throw in that in Germany, a lot of cases that are normally treated in outpatient settings in other countries, particularly in the Danish setting, for example, is treated in hospitals, thus having a lower risk or being medically lighter patients. So I find nurse comparisons of ratios between different countries always a bit tricky for the German sector. Wondering how you want to take that into account. Thanks.
We have another measure, and that is we have to take what is available from the OECD in this case, because we have to use the the data we have available, and there we have, but we have the number of nurses per case, and the picture does not look so very different. But thank you, Ricarda, for this idea. Maybe also the nurse to patient ratio would be available. I would need to search for that data, but also when looking at nurse ratio per caseload, it is the same picture. And this is striking because the absolute number of nurses and doctors is not so bad in Germany, but as soon as you relate it to the cases, it is bad. And of course, the number of cases, this comes together with a payment, the activity-based payment system we use in Germany, the DRG system, which provides some incentives to augment the number of cases. So this is this is very interdependent with many factors, and information which could be interesting for you is that we have a lower we have a minimum number of nurses to patient ratio in Germany, but this has been suspended during the first wave of the pandemic. It has been reintroduced only recently.
Okay, thank you, Mirella. I think we are running out of time now. So thank you very much for your presentation and for the whole discussion here. I really enjoyed that. And then I would go over to Rocco